This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
I get the opportunity to talk about the 3 Ds and what to do about them: depression, delirium, and dementia. And I'll try to take this more from a prevention point of view. So this is what we want to look like as we get older. I actually co-opted this slide from the National Institute of Mental Health, which has been losing funding every year for the past 10 years. But this is what we want to look like. These are young, old individuals who have friends with each other, they're walking on the beach, and they're very robust and healthy. And this is what we all strive for. And this is life expectancy, and so, in the year 3000, we're going to be living forever. But that's actually not true, and I'm not even sure that we want to live forever. I'm not sure that's what the goal is. The goal is to live well and not to become decrepit. And actually, when I ask patients what some of their fears are as they get older, their main fears are to lose intellectual function and to have pain. I think those are some of the things people get frightened of. When things started to really take off here, it wasn't because physicians got so much better. It was probably because the infrastructure got so much better, and we got indoor plumbing. But we'll take credit for it as physicians, why not? What are some of the diagnoses that are associated with mental status changes in later life? Well, changes in mood, and then changes in intellectual function. And there are 2 kinds of changes that occur. One is delirium, which is the reversible kind of cognitive change that's often associated with a medical illness. And theoretically, if we were to get to the bottom of the medical illness, then that kind of cognitive change will disappear. Sometimes it's alcohol or medications or some type of illness. And then the second, dementia, is a cognitive change that occurs from a neurodegenerative process. And we'll be talking about all of these and defining them in a few minutes. Okay, why don't I talk about depression first, because it's depressing, and that way we can get it over with. Okay, so if you're from New York, depression is realizing that the light at the end of the tunnel is New Jersey. But psychiatrists actually have a diagnostic and statistical manual, which is a group of descriptors, because we don't have animal models for our disorders. And so what we do is compile lists that actually describe depression. You don't actually have to have depressed mood to have depression. And I'll frequently have patients who say, but I'm not depressed, and yet somehow they'll meet criteria for depression anyway. So you have to have either depressed mood or a pervasive loss of interest, and some of these other things. And what people can have are changes in appetite or weight, and changes in sleep. And usually the change in sleep is people have ease falling asleep, but then trouble staying asleep. They will have changes in demeanor, such as really slowing down and losing motivation, or they can become quite agitated. Real trouble with just sitting in a chair, not wanting to move. Often when they're sitting in that chair, they will think about times past and think about things they could have done differently, things they should have done, and along with that they may feel quite worthless. Poor concentration and distractibility, such that, as we'll see in the next slide, that can be confused with actual dementia. And some people may think that life isn't worth living anymore and get suicidal. Now, there was a term that was coined in the 1960s called pseudo-dementia, and sometimes these days that word floats around. The concept behind it was, don't confuse that poor concentration and distraction that results from depression for dementia. This is really depression and you should treat it. Now we've come full circle and we've started to think that actually don't confuse the poor concentration that accompanies with depression. It may actually herald dementia. And so we really don't use the term pseudo-dementia too much anymore. On follow-up, many patients, particularly those who've never had depression before in their lives and are starting to get depressed now after age 60, these people may actually have full-blown dementia after several years. And this dementia may actually present with loss of motivation and loss of personality. What kinds of things can actually cause or depression? Some of the medical conditions that are associated with lack of oxygen. The brain gets very upset when it doesn't have oxygen. And so the medical conditions like asthma, bronchitis, chronic obstructive pulmonary disease, cardiac arrhythmias like atrial fibrillation, congestive failure, and thromboembolic disease. Sometimes people can go to the emergency room with depression and get a very cursory medical clearance. They're so depressed, they look so psychiatric that they'll be cleared very quickly. They'll come up to the psychiatry service and we'll actually make some of the medical diagnoses once they're up there. Many geriatric psychiatry services are actually medical psychiatry services as well. Now, depressive symptoms can also give rise to a poor prognosis if somebody also has cardiac disease. And this actually came out this year. I put this slide in today, actually. Type D personality is a kind of depressed, irritable personality in an individual who doesn't like to express those kinds of symptoms, and so they hold it all in, and they can wind up becoming very stressed. So this study was done in individuals who already had coronary heart disease, and they were followed after 5 years. And what they found in this study was that there was almost a 3-fold increase in actual cardiac death in people who met these research criteria for a type D personality. And the cardiac death was from a heart attack or coronary artery bypass and graft. This is one of the few acronyms I'll use as a CABG, or percutaneous coronary intervention. So it's very important if somebody has such a personality to try to get treatment for that, and that may actually decrease the risk. Well, how pervasive is depression in older individuals? Well, it's actually, minor depression is a term obviously that doctors dug up. It's not minor for the patient who has it. So it's sort of like minor surgery, So in hospital settings, it's actually quite pervasive. In primary care settings, a little bit less so. This is actually, I thought, interesting because there are individuals in the community that actually meet criteria for major depression, which are those symptoms that I discussed a few moments ago. This was a study that was done by the folks at Duke quite some time ago, where they actually went into the community and did very rigorous screening. And they found that, again, just like the other slide, only 1% met criteria for major depression. But if you compile all of these other folks, up to 1/3 of them had some kind of depressive symptoms. And so the bottom line here is that there's a fair amount of suffering going on, even if people don't meet the full-blown criteria for depression. And so what that means is that even though our diagnostic and statistical manual may not have people meet criteria, there is suffering going on in older adults living in the community. And these people need treatment, whether it's with psychotherapy or some kind of treatment. We're letting it slip by. And there may be all kinds of reasons for this, whether it's pain or the way people are living in communities. It needs to be further explored. Well, why is that? They don't need treatment just because of the individual misery, but also because depressed patients require almost twice the number of medical appointments of non-depressed people. And so this actually puts a toll on the medical system. And this, as you can see, is from quite a large sample size. Primary care physicians have had difficulty assigning the diagnosis. That may be because, supposing in a managed care situation, you ask a patient, "How are you feeling?" They may tell you. And if that happens, it may make the doctor over time for the next patient. And so I think doctors have had a hard time with this. It's very difficult. It's much easier for the doctor to say, you know, how's that, you know, wrist pain? Then, you know, the visit can be shorter that way. It's difficult, though, because 75% of older suicide victims have seen their physician within the last month of life, and 25% have actually seen their physician within the last day of their lives. And so doctors are missing this. This was done in 1996. I read a more recent study where it was up to 50%. So I think primary care doctors are getting a little bit better. These doctors in this study actually had a training course right before the study was done. So I think with better education, doctors will get better at assigning the diagnosis. Well, the rate of suicide, say, I told you I wanted to talk about this first. It's kind of depressing. So older white men have the highest suicide rate of any group, 67.6 per 100,000, compared to younger African American women, where it's 5 per 100,000. They don't have time. So here's what it looks like, and I'm sorry I don't have this in color, but you can see how it really takes off here after retirement. This is, interestingly, white retired women. So after they stop being the caregivers, it goes down. So I won't interpret that. This is African American men, and this is African American women. Now, so how do we optimize our mood? There are several things that we can do. As people start to retire, they need to think about how they're going to make this transition. And for people who have worked, they need to start to make that bridge. And so there are things you can do. You can start to put structure in your day and think about how you're going to do that. If you've always been a worker, get an all-encompassing hobby prior to retirement. Make each day count, whether it's by volunteerism, having friends, as in that photograph that I copied from NIMH, having family. One study suggested that especially women who had friends outside of family tend to do better than family. Maybe it has to do with that caregiver role. We'll talk a lot about non-essential medications in a few moments. My editorial comment is to get a pet. There have been some studies suggesting that when a pet walks in the room, the blood pressure goes down. They also give you responsibility. They make you feed them, and they make you go for a walk, and they're also cute. Avoid stress. And I say that because there is a physiologic factor behind stress. So there is this entity known as the hypothalamic pituitary adrenal axis. So the hypothalamus, which sits in the brain, secretes a hormone, which makes the pituitary then secrete a hormone. That goes to the adrenal gland, which makes cortisol. Now, normally, there's one stimulus, you know, the lion who's chasing you. You secrete cortisol, and then it feeds back to the hypothalamus, and the hypothalamus says, okay, I got my cortisol, I'm going to stop making my hormone now. Now, if a person is constantly stressed, this becomes abnormal, and actually this negative becomes a positive, and it keeps on going in a loop like this. And this cortisol can actually go back and damage a part of the brain that's known as the hippocampus, which is very responsible for memory, and we'll talk about that in a moment. So here's this loop. So the increased cortisol, which can cause the hippocampal death, will decrease, as I mentioned, the inhibition of that hypothalamic hormone That'll then increase the pituitary hormone, increase the cortisol, more hippocampal death. So you get what I mean. There's this cascade going on here. That will cause the atrophy. Now, the chair of our department, Dr. Schatzberg, has been working on this when it comes to psychotic major depression and early dementia. And you can see there are a number of other disorders here where this may become a factor. So when I say decreased stress, I mean it. Now, you don't have to be a radiologist to see this little part here is the hippocampus. It's concave in a patient with Alzheimer's disease, and it ought to be more supple. It ought to be convex here. Now, all of these studies on the stress response, this fight or flight response, have been done in males. In 1932 is when it started, and until 1995, only 17% of the studies were done in women. And the reason for this is actually straightforward. When you're starting to look at a phenomenon, women under stress actually secrete oxytocin from the posterior part of the pituitary, and that would be a confound. And so very often when you're starting to study something, you start by looking at the relatively purer phenomenon where oxytocin is not going to be studied. These days, however, it may be wise to start to look at what women do now that we know what the male response is. And so women who don't secrete a lot of testosterone and do secrete a lot of oxytocin may have a different stress response in addition to the cortisol response. So some women from Southern California are starting to really look at whether or not women have a slightly different response under chronic stress than men. And it may be that in addition to some of the societal modulators like family and other environmental modulators, women may actually be more biologically induced to seek out social networks as a response to chronic stress. And so this may be something that turns out to be quite important, and is there is a major center now at UCLA that's looking at this. Now that I've depressed you all, I think we should go on and maybe look at aging and memory. A previous president from the American Psychiatric Association said, when it's quiet I can almost hear the brain cells drop out, and I would posit that maybe he should not be around quiet. Let me start by talking about delirium. And delirium is, as I mentioned, this reversible phenomenon of intellectual impairment, which means if you were to evaluate a patient with delirium, just at one moment in time, you may not be able to distinguish that individual from somebody who had dementia. It usually begins at night with somebody being confused and perhaps agitated. Classically, and by definition, it consists of a waxing and waning level of consciousness. So I may walk into a patient's room, and with my delightful sense of humor, I'll be talking to him and or her, and they will fall asleep in the middle of the interview. That should be an index of suspicion for me that this individual is suffering from delirium. The person may have disorganized thinking. They may misinterpret sensory stimuli. They may have these Salvador Dali-esque kind of illusions, or they may frankly hallucinate. They will not be able to maintain attention. They may have a startle response at one moment or become somnolent the next. And very interestingly, these clinical features will fluctuate. And so sometimes the patient may appear completely normal. And the times that they may be normal are usually in the day, particularly on doctor's rounds, so that it starts at night. And part of the reason delirium may have a grave prognosis is because it takes a while for it to be diagnosed. Now, how often do we see it? On medical wards, it's actually fairly common. Prevalent means when a patient presents to the hospital with it. An incident means when it occurs while in hospital. On general surgical services, you would expect to see it less often because it's likely a surgeon would not want to operate on somebody who's experiencing delirium. But you can see that hip fracture patients suffer from it fairly commonly. Older age is actually a risk factor for delirium, and we'll talk about that in a moment, and it should not be at all present in the community, really. So what are some of the risk factors? Well, visual impairment is one. Somebody who has severe illness, somebody who already has a dementia such as Alzheimer's disease would be at risk for also suffering from delirium. And that's what can be very difficult at times, because somebody who's, let's say, in a nursing home who has a chronic stable dementia and all of a sudden has an exacerbation of dementia. Well, is it an exacerbation or is it delirium? If it is a delirium, is it from urinary tract infection or pneumonia? Those would be the two most common reasons. And also kidney disorder. In older patients, it's important to try to avoid the use of physical restraints that may predispose somebody who's malnourished, and that can easily happen as somebody gets older. Bladder catheter, and more than 3 medications. It's very difficult to stay off of 3 medications as somebody gets older. There was a study done recently that showed that a very low dose of the antipsychotic haloperidol prior to surgery in patients who are already at risk for delirium does not prevent the incidence of delirium, but it does decrease both the severity and the duration, as well as overall length of hospital stay. So not that we're all prescribers in this audience, but it's something to actually think about. And this is a very new study. Why don't we move on and talk about dementia? So dementia is a loss of global intellectual function, and it's caused by some neurodegenerative process. So we don't expect dementia to be reversible. Now, you'll notice this does not add up to 100%. And that's because different studies will say different things about what causes it. The Canadians found in a large sample in 2000 that 64% of the patients with dementia up there had Alzheimer's disease as its cause. Dr. Bruce Miller's group found that of all the neurodegenerative disorders, frontotemporal dementia was the cause in 12 to 16%, and I don't plan to talk about frontotemporal dementia this evening. Vascular dementia accounts for up to 1/4, and I don't mean strokes here. What I mean is very, very small blood vessels that just lose the ability to cater to brain tissue. So I've been using the term cognition and intellectual function pretty interchangeably, so I thought maybe what I would do is define the term. Cognition is one of those words like obscenity. We sort of know what it is, but it's hard to describe. So cognition consists of short-term memory plus one other area of intellectual function. And those areas can include praxis, which is the ability to do things, such as tie shoelaces, put on makeup, put on clothes, that sort of thing. Stereognosis, which is the ability to perceive things by touch. So you can go in your pocket and feel the difference between the quarter and the dime. Attention, motivation, and executive function, which is the ability to plan things. Alzheimer's disease is not of a very sudden onset. So when somebody asks, well, when did this start? Usually their answer is, I don't know. The family member will say, I don't know when it started. It happened so insidiously. Very prominent and very early on, word-finding deficits. Can't find the right words to express yourself. People will develop a vague, rambling kind of speech. Social skills are preserved until very late in the course. People will preserve their continence until very late. Dr. Alzheimer, when he first made the diagnosis, found these plaques which are in the brain tissue and these tangles which are inside the nerve cells. And that's a certain number of plaques and tangles per microscopic field is still to this day what makes a definite diagnosis. Vascular dementia, real quick. CT scan and MRI can often help to make the diagnosis. Very commonly, patients will have high blood pressure, high cholesterol, and a history of smoking cigarettes as well. And they will also have some vague neurological findings on neurological exam as well. Unlike the individual with Alzheimer's disease, people will plateau in their course, and then it's as though if there were a real small change on brain, all of a sudden they'll have a dramatic deterioration in their cognition, then they'll plateau, and then they'll have another dramatic deterioration. So that's known as a stepwise deterioration. So how do we optimize memory? We used to think that there isn't much we can do, and it turns out there actually is. Mental gymnastics. I think Dr. Gary Small from UCLA wrote a book called The Memory Bible, and even though he's from UCLA, it's still probably a good book. The brain is not a muscle, but if we treat it like one, we can exercise it and help. And it may help to actually prevent cognitive decline, and once somebody has early Alzheimer's disease, it may help to ameliorate things a little bit. So try one new cognitive endeavor every several years. Learn a new language. If you already know a Romance language, then try Chinese or Greek or Russian and really make your brain work very hard. Try a new card game. If you've never learned bridge, try bridge. Learn to dance, and we'll talk about that in a moment. Tai Chi turns out to be one of the only things that you can do to keep your balance, which is why most senior centers offer Tai Chi. Avoid medications that can make your memory worse. Avoiding obesity is something that is very important from the point of view of cognition. Optimize near vision and avoid stress. As I mentioned before, that's not only important for depression, it's important for cognition as well. So I mentioned leisure activities, dancing. This was a study that was done you have to be aware of studies like this, number one, because this was a prospective study where they took a group of people and then had them do certain things and then watched to see who turned out to get dementia after 5 years. And it could be that people were already starting to get dementia at the beginning of the study, but it wasn't known. And so those people may not have wanted to do these things like dance and so forth. So one always has to be a little suspicious. But in any case, with that caveat, dancing was the only physical activity associated with a lower risk of dementia. They didn't have enough power in their study to see if golf or tennis was also worthy. So if you're golfers or tennis players, don't stop because of this slide. The cognitive activities that were associated included reading, playing board games, playing musical instruments. Now I must say what dance and reading and playing board games have in common are associations with being with other people. These are all social activities. So that may have a lot to do with it as well. Interestingly, you didn't have to do this a lot to have even a small reduction in the risk. So they're not telling you to be the belle of the ball. So avoid medications that may make your memory worse. This isn't because it's my area of academic interest. It turns out to be true. Now, we talked a little bit about the hippocampus. This is an area that's deep in the brain, and neurons, nerve cells, are like telephone cables. They have long projections. And so here you can see it goes to the front of the brain, which is responsible for abstract thinking, and to the parietal cortex, where there's language, and to the occipital cortex, which is responsible for visuospatial things like reading maps and so forth. This hippocampus is actually a center where a neurochemical called acetylcholine modulates all of these functions. So any medication that could potentiate or hasten or make stronger acetylcholine's function, you would think would possibly help people with Alzheimer's disease, and that was certainly some of the theory behind some of these medications that we prescribe. And any medication that would decrease the effect of acetylcholine would actually hasten dementia possibly, and certainly cause delirium. And that does turn out to be the case. So this is a cartoon that is taken from Stephen Stahl's book. And if this is the business end of a neuron, and so the axons would be up here someplace, and this is how acetylcholine is made with all these chemicals. So a stimulus happens, and acetylcholine is extruded into this gap between two nerve cells. And once that happens, it's immediately gobbled up by this enzyme here, which is known as acetylcholine esterase. So if you can somehow stop this acetylcholine esterase from doing its work, you might be able to potentiate the effect of acetylcholine. And so that's pretty much what the Alzheimer drugs attempt to do. So they're called acetylcholinesterase inhibitors, or cholinesterase inhibitors. So we'll talk about those in a moment. Now, anticholinergic medications are the ones that you would want to avoid, theoretically, in order to enhance your cognition, or at least not make your cognition worse. And it turns out there are a large number that we can't help but prescribe because they're very good for some things. For example, they're great antihistamines, by and large. They're great for asthma. They're great for balance in people who have vertigo. They're wonderful antidepressants for migraine headaches and for pain, and we still use them as the standard antidepressants very often, and they're good for bladder. And so I'm just talking from the point of view of memory. You may find that some of you in the audience are taking these medications, and that's fine. It just needs to be weighed against the cognitive side effect. These are other medications that, to a very minor degree, have anticholinergic effects as well. Lasix, digoxin, Coumadin. Now, none of these is strongly anticholinergic, but when taken all together, they may present something of an anticholinergic burden as well. And that's compared to these medications, which are not at all anticholinergic. Now, through a completely different mechanism, benzodiazepines can also be deleterious to cognition. And so, again, they're absolutely wonderful for anxiety and for sleep. And so they just need to be weighed against the possible cognitive side effects. Anything that ends in EPAM or OLAM is a benzodiazepine. I didn't put trade names up here. These are the cholinesterase inhibitors, and they represent the first class of medications that were available for the treatment of Alzheimer's disease, and they're also useful for vascular dementia as well. And they don't improve. All three of them have the same graph here, and none of them improve cognition. They do seem to prevent magnitude of decline compared to patients taking placebo or sugar pill. And there were studies done in the United Kingdom that suggested that they don't seem to prevent time to nursing home. But I do think it's safe to say the standard of care in the U.S. is that we do prescribe them. They do seem to help to stave off magnitude of decline. So some people prescribe them, some people don't. I tend to prescribe them. I think a lot of it has to do with cost, and if it's a question of being able to afford this medication versus others, the others may be a better bang for your buck. This represents a different class of medication which works through a completely different mechanism. On the stress slides with cortisol, you may have noticed that glutamate, which was an excitatory neurotransmitter, is also stimulated through cortisol reaction. Glutamate is one of those very ubiquitous neurotransmitters that we need for cognition, but when it's abnormally secreted, it can become toxic. So what memantine does is it restores to normal this particular group, and again, it does not help cognition, but it does prevent decline. So another way to optimize memory is to avoid obesity, and this was a study that was done here at Kaiser on 10,000 individuals. They followed them for many years, and they were able to tease out obesity from diabetes, high blood pressure, and stroke, and heart disease. And what they found was that if somebody was had a body mass index over 30, they had a 74% increased risk of dementia, and people whose index was over 25 had a 35% greater risk of dementia. So it was a very interesting study because it was one of the few that was able to tease out people who were obese versus people who had some of the concomitants of obesity, like high blood pressure and diabetes. Now, near vision is another thing that I wanted to talk about because it's something that it seems like it should be fairly easily correctable. And there was a gentleman in Texas who looked at 2,000 Mexican Americans that were over 65, and he looked at the usual rating scale that we use, and he had a blind adaptable form for it to look at people's eyesight, and he followed them over a 7-year period. And what he found was that over 7 years, the people who had adequate vision did not decline on this cognitive exam the way people with near vision loss did. And he compared that to people who had far vision loss. This is not significant. And he also, interesting, compared it to people who were hard of hearing, which was not a significant finding either. Now, what is it about near vision loss? Well, people who lose their near vision lose a lot of stimulation. They can't read. They can't read nuances of facial expressions in people who they talk to, and they can't do a lot of things like their own hygiene, putting on makeup, shaving their face, that sort of thing. So it's not just the vision loss itself, it's the things that you're unable to do once you lose that vision. So it's very important to keep seeing your ophthalmologist or optometrist and keep up with that. The question was, the gentleman is using glucosamine, and does that have anything to do with glutamate? And the answer is no. Glucosamine has no relationship to the glutamate, so I think you're safe on that one. The question had to do with differentiating between Alzheimer's disease and vascular dementia. What I frequently do is when I'm making a diagnosis, I will sometimes have patients go to a neuropsychologist to have formal memory testing done. I'm usually pretty careful in getting a history of, in differentiating between vascular and Alzheimer's disease. I'm careful to try to get a history of stroke and high blood pressure and all those concomitants. The other thing I can do is, when you've been around the block enough, sometimes you can tell by speech, because people with Alzheimer's disease develop a certain speech pattern that's really almost diagnostic. There is a neuropsychologist in Boston named Marilyn Alpert who swears she can almost make the diagnosis just by looking at somebody's speech patterns. I think neuropsychologists can come in very handy. The MRI in somebody with vascular dementia should also help substantially to make the diagnosis. Somebody with Alzheimer's disease should have an MRI that looks like this, and I will show you. This is a normal brain. They say normal aging brain. That's when a 20-year-old radiologist is talking about a 55-year-old's brain. But if these are, this is the eyes and nose, this is the back, and if these are the ventricles, which are the spaces that bathe the brain with cerebrospinal fluid, and these are the sulci, which are the folds that give the brain extra surface area. And you can see there's not much space here. And you can see that these are very widened here, and that the sulci here are also very widened, and that's consistent with big-time atrophy of the brain. So that's what you would really expect to see in somebody with Alzheimer's disease. You can get PET scans if there's positron emission tomography scans in somebody, or SPECT scans, if you really think that the diagnosis is in question and it would change your treatment. The question is the effects of anticholinergic drugs. Are the effects permanent? That's actually my area of academic interest. It's very likely that the effects are not permanent, and that if you take the medications away, it should be reversible and the person should get their cognition back. At least that's what we've always thought. The question was the connection between dementia and hip surgery, and that was actually a slide on delirium and hip surgery. And it was an interesting connection, because I think that many of the people who go in for hip surgery are older individuals, and when you think about it, they've fallen, which is why they need hip surgery. And so one of the questions that I would ask is, what are the circumstances under which that patient has needed hip surgery, and could they have been delirious as the antecedent for the surgery itself? I do think that it's a very interesting question, and many people who do go for hip surgery come out of that surgery with delirium. This is a very frail population. There is a big literature now on people who go in for coronary artery bypass and graft surgery, who leave that surgery with very successful coronary arteries, but who have confusion and then dementia later on. And it does not have to do with the surgery itself or the anesthesia, and it's kind of a hot area right now, and it may have to do with the genetic predisposition that they have for Alzheimer's disease. The question was about the speech patterns in patients with Alzheimer's, and it's a vague, vacuous, rambling kind of speech, almost as though by the time the individual gets to the predicate, they forgot what the subject was. And so it trails off. And I hate to say this, but if you've ever read President Reagan's old press conferences from the New York Times, you can see that there. And I'm not saying that he had Alzheimer's disease when he was president, but that speech style was there. What is the standard of care for the cholinesterase inhibitor drugs? I think the vast majority of people that I know and that I talk to, at least in this country, do start a cholinesterase inhibitor on a person with Alzheimer's disease. And probably even with mild cognitive impairment as well, which we didn't talk about this evening, which is the very mildest form of cognitive deficit. The sense is that it does stave off the cognitive decline somewhat. It does seem to help caregiver burden. And while it does not seem to prevent time to nursing home, it does really help, I think, patients' dignity as they maintain their cognition for a longer period of time. And my experience is that it helps the behaviors as well. There are 3 cholinesterase inhibitors that are on the market right now, and they're all similar to each other. So there's no preference of one over the other. They're all really the same, you know. The one that was on the market first was donepezil. Then I think rivastigmine was second, and then galantamine was third. The question had to do with the selective serotonin reuptake inhibitors, and do they act on cognition? Is that what you mean? No, they do not. They have virtually no. There's one of the SSRIs is very slightly anticholinergic, but not at all to that degree. The question is, does one add the Namenda or memantine onto a cholinesterase inhibitor? And the answer is yes. The question has to do with if the patient's already been diagnosed and is already on treatment, is neuropsych testing overkill? I think it's very variable. If it seems like the patient is really doing well or is stable and they're on medications, the one reason to get neuropsych testing is just to see whether or not the patient is changing over time, but very often the doctor and the family can really do that together without need for neuropsych testing. So I think sometimes it's useful if the diagnosis is in question or if you want to carefully monitor the symptoms over time and see how well the patient is doing over time. But I don't think it's always necessary. The question has to do with the blood urea nitrogen and creatinine. That has to do with, those are reflective of kidney function. And they have made correlations for years between kidney function and risk for delirium. It's as if when these toxins may build up, they go right into they go right through the blood-brain barrier and right into the cerebrospinal fluid and make people potentially delirious. I think that's a great question, and it's one that we all ask as we're getting older, is when is it normal aging and when is it something that we need to worry about? And one of the definitions of dementia is an operational one, when it starts to interfere in your daily functioning, and when your family starts to notice that it's interfering, that's when you start to worry. So if your family is starting to, drag you by the ear, or, if they notice that there's a real decline, part of me, what a lot of doctors would tell you is that if you're asking the question, you probably don't have it. But I don't mean to be facetious either, because I've met people who've said, I know me, and I think that there's a real change here, and I'm not depressed, but I notice certain things. I don't retain information the way I used to. I have to use post-it notes all over the place that I didn't have to do in the past. And if you seriously feel that you have a cognitive problem that's different from all the other people that you know that are 83 years old, then maybe you should get evaluated, because that may be the only way to assuage your anxiety about it.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.